Well, thank you very much for that welcome, Stephen. And thank you to Canada, if I may say so, for a welcome. My wife and I have been in this country a few days, and it is a hallmark, I think, of your country, how welcoming everybody is. Needless to say, being here, I undertook a bit of an informal survey, and on a ski lift not very far from here, would ask a few people what they thought about your healthcare system. And if I ask the same question in England, although many would think we have one of the better health systems in the world, invariably people would complain. Here, your public said to a man and a woman that they thought it was very good. And so I just passed that piece of information on to you. So given that, I'm somewhat wondering what on earth it is that a lawyer, and a medical negligence lawyer at that, from England can say to help you. And I come from a country where when we talk about the Winter Olympics, it's we express amazement if anyone is even thinking of winning a medal, whereas here you just seem to take it for granted. But there we go. Just the next, I suppose it'll be about 40 minutes. If it's longer than that, my wife will start waving at me. I'm just going to talk to you a little bit about the Stafford inquiry, what went wrong in a perfectly respectable part of England where no one thought anything really could go wrong, what the reasons for that might have been, and some of the remedies that we're looking at now in this country. But starting with some background, I'm sure most of you in this room will know a little bit about the National Health Service, but I think it's always worth reminding ourselves what an enormous enterprise it is. It aims and does provide free healthcare at the point of use for the 63.2 million residents of the United Kingdom, and I might say a lot of people who pass through and visit, and we've got a bit of a discussion going on now about how we can ask some of them to pay, but that never seems to work. It has more staff, it is said, than any organisation in the world other than the Red Army, Walmart, and the Indian Railways. And hard-working to a man and a woman they are, and often completely undervalued in my view. 1 million patients are seen every 36 hours. 114 billion pounds, if I could decipher the Department of Health's budget from the documents last year, or for the current year, and that's a huge proportion of what the government spends out of taxpayers' money. So it's a huge operation, and of course to run that is very complicated. This diagram, which I don't ask you to learn, came out of a report which, entirely by coincidence, was published by the government the very day my first report on Mid-Staffordshire was published. And it set out to describe to the public how the responsibilities lay for detecting early warning signs in the National Health Service of something going wrong. And what this diagram doesn't really tell you is how many different organisations have some responsibility in our country for monitoring, overseeing or regulating the quality of care provided to patients in our hospitals. I got up to about 50 and then stopped counting. Although I was able in my inquiry to look at the actions of some of them, I wasn't able to look really at all of them. And I think there is a danger in complexity. It's necessary, of course, in many ways, but it is much easier for things to fall through the cracks. Stafford, you will now probably have heard of as a result of the appalling events that happened there. But that is Stafford Hospital. Stafford is a perfectly unexceptionable market town, almost bang in the middle of England. It's not geographically isolated. A motorway goes past it from London up to Manchester and Liverpool. It's 20, 30 miles from Birmingham, one of the biggest conurbations in the country. It is surrounded within a 50-mile radius by 5 or so other district general hospitals. And yet there was something about it that made it completely isolated, a place which people went past, didn't really observe what was going on there. Those who worked there, some, I'm afraid, probably went there for a quiet life. As a building, I don't know what your hospitals look like, that was built in the 1980s. It didn't get off to a hugely good start because, unbelievably, mine was not the first public inquiry to happen about events at that hospital. In 1986, there was a public inquiry because of an outbreak, a serious outbreak of Legionnaire's disease, causing a number of deaths. And a quite seminal inquiry took place dealing with how to prevent events like that happening. The report of that inquiry praised the compassionate and dedicated care given by the staff at that hospital in a crisis. Unfairly, but I'm like being unfair, just 2 points about the geography of this hospital. I ask you to note where the Chief Executive's office is in the top right-hand corner, with a third floor, I think it is, with a very nice view looking out over the trees. Right at the opposite end of the building, you will see the arrow. There's an arrow pointing to the trade union, that is staff representative's office. When I say office, I'm actually pointing at a caravan in the car park, which is next to the car park attendants caravan. So you keep the staff representatives as far away as you can from the centre of activity. And just because it's always important, isn't it, the Hospital Records Office is that very large roofed building at the side where all the paper records are stored in something rather similar, I think, to a sort of pharaoh's tomb. And the sooner we can actually ditch all that stuff and get electronic, it seems to be so much the better. But we in the NHS have been trying to do that for a number of years. So, as I've already mentioned, I chaired 2 inquiries, but let me tell you a bit about how all that came about. In April 2007, the Daily Telegraph, one of our national newspapers, published a report from an organisation called Dr. Foster, which set out in a sort of league table form the mortality rates for all the hospitals in England. The Stafford Trust turned out on this scale to have something like the 4th highest unexpected mortality rate of any comparable hospital in the country. Significantly, you might think, of the top 10, or bottom 10, whichever way you look at it, organisations, 6 were in the West Midlands. I don't ask you to look at the figures there, but what it turned out was, when looked at later, was that this measure of mortality outcome was steadily rising. 100 is fine, less than 100 is good. Anything above 100 gets more and more surprising. And you can see it got up to 2007, 127. So concerns began to be expressed about that figure. The immediate reaction of the Hospital Trust and those overseeing it was not to ask, well, why is this happening? We better go and look at the individual diagnoses and see whether there's a problem with the care being provided in wherever it is. Instead, an outright attack was made on the credibility of the methodology. Now, the methodology is still being discussed today, and it's by no means perfect, but an academic study was commissioned to look at the flaws in this, while at the same time no case note review was being undertaken. So concerns began to be expressed. I don't know if you have a regulator here, but we had at the time the Healthcare Commission, a regulator of safety and quality, and their own mortality alerts began to rise, and they began to notice that when they told the hospital trust about these, that nothing was done. Or if they got a reply at all, it would be to deny that there was a problem. So they were beginning to decide they would launch an investigation. And then, roughly simultaneously with that, the patients, or group of patients, got together because of the experiences they, or more usually, I'm afraid, their now deceased relatives had had at this hospital, and began to protest about the care because no one in the hospital trust was listening to their complaints, and they called themselves Cure the NHS. And this picture is taken in a cafe in the middle of the town, run by their leader. And on the wall, she plastered all these photographs of mainly dead relatives and the questions that they wanted asking. These were just ordinary people with no previous experience of doing more than complaining about the quality of their meal in the restaurant, who suddenly found themselves having to run what became a national campaign. And they still haven't given up to this day. They've had to give up their lives, in effect, to campaigning to see things change because they don't want what happened to their relatives to happen to anyone else. The lady in the middle of the photograph is Julie Bailey, who's recently received an honour in the New Year's Honours list, and quite rightly so. And she will not rest until things have got better. We'll hear a bit. Her mother died in this hospital in pretty appalling circumstances. She's there holding a copy of my first report at the press launch for it. And on the cover of it, she's written, another government whitewash. She wasn't hugely happy with that, and quite rightly so, no doubt. Unfortunately, she left that copy of the report at the conference, and I now have it at home. We seem to be rather good at producing reports in our country. What happened was that the Healthcare Commission undertook a year-long investigation into this hospital and produced what can only be described as a damning report into what they found, and we'll look at some of the things that went wrong in a moment. It caused a furore, and it caused Julie Bailey and her friends to demand a public inquiry. But they didn't get a public inquiry. First of all, they got two reports by very distinguished and eminent people, one looking into the problems in the emergency department and the other into how it was that the commissioners of care had not spotted what was going wrong. But that didn't satisfy them. So they then got me. The government appointed me to write the first report, to listen to the patients of Stafford Hospital, to hear their side of the story. And that inquiry lasted about 9 months. And for 6 weeks of that, I sat in a quite small room, listening in private, albeit with a few people helping me listen. 2 families come on the rate of about 3 a day to tell me about the appalling things that had happened to them and their loved ones in that hospital, being quite apparent that although many of them had complained, they didn't feel that anyone had listened. Overall, and I'm talking about a period of 2005, 2009 is what I was looking at, some 900 people wrote to my inquiry to tell me about those experiences. Some, 200 or less than 200, of course, told good stories, and the rest were bad. Now, obviously, it's a self-selecting sample. But in terms of a percentage of the number of people treated at that hospital, of course, that was all. It was really quite small. But actually, when we look at numbers, we satisfy ourselves that we have an 80% satisfaction rate, or an 85% satisfaction rate, which is an improvement on the year before. If you convert the 15 or the 20% into actual numbers of people who've actually had something go wrong with them, you would add to that number the families who are also affected. And you soon end up with a huge number of people who are dissatisfied with the service that they've provided. And if that sort of figure was tolerated in a retail organisation, it would probably be out of business really quite quickly. And I think we need, in our country, to change the way in which we look at things that are going wrong, so that we trumpet and celebrate, of course, the things that are going well, but we never forget what's not going so well. Anyway, the result of my first inquiry, in which I unwisely recommended there should be a second inquiry into the wider system, resulted in me spending 2.5 years on the next one and producing the report at the end of the top row. I made, at the end of that, famously or notoriously, whichever way you look at it, 290 recommendations for change. But apparently, I can say this out a long way from the United Kingdom, that wasn't enough. And since then, we've had all those other reports which have made a number of other recommendations, none of which, I have to say with some pride, are inconsistent with what I said in the first place, but many of which, to be fair, actually add to the wealth of ways in which change can happen. We'll come to some of the things, as I said, which went wrong, and the actual stories in a moment. But was this a one-off event? Was this hospital so terrible that it was like Dr. Shipman, something that wasn't happening anywhere else? Well, I'm afraid in our country the answer is no. The things that were found there can be found in any hospital in our country and are actually found in many of them. And we've had a number of reports which have shown that, of patient stories, of the Care Quality Commission's reviews of a number of hospitals have found appalling things if you go and look for them, and things which have to be changed. So what went wrong? Well, just what you might think is a trivial example. A relative just told me about watching a very humane, compassionate, no doubt, and friendly cleaner going round a ward with a cloth, cleaning windowsills, cleaning the bed, going into the toilet with the same cloth, cleaning that round there, coming out again, and still using the same cloth. Now, something that could happen, I'm sure, in many places. But what was being done about it? What did it show as a story? It suggested to me that there was someone who hadn't been trained properly, someone who wasn't being supervised properly. But that sort of thing you might think could be corrected. But then what about this? The daughter of a patient in a ward told me that you could hear the buzzers going. You could hear buzzers sounding. You could hear people crying for the nurse and no one coming. This is a ward full of elderly patients, of course, who needed help to go to the toilet. And what struck me about this story was how after the sobbing, everything went quiet. And you realise, it seems to me, that you're not just dealing with people who are losing their dignity because they've got to go to the toilet in the bed and no one is doing anything about it. But you've got people who, because of that, give up. And at that age, or probably any age, if you're ill, vulnerable, and on your own in a hospital, you give up. I'm afraid some of people are going to die. One of these patients, and another story, which I haven't put the slide out, it's too near to breakfast, was found by her relative naked on a bed in a room with a door open, so everyone walking past could see her naked state. She was covered, according to this witness, in feces, put graphically as being in her eyes, in her hair, under her fingernails, and on the bedstead. And it was dried because it had been there so long that it had time to dry. And you ask yourself, how could something like that happen in a well-run place? And the answer is it can't. What is it that allowed nurses to walk past and think, oh, I don't have to deal with that now? How many doctors must have gone past and not thought it was their business to get someone to clean this poor lady up? How could it be that a place could become so institutionally uncaring in a big major hospital in the middle of my country that something like that could happen? And we then turn to people who did complain. And you won't, I'm afraid, see that very clearly, but that's an example of one ward where patients fell and broke bones. Now, falls with elderly patients are unhappily only too common. But quite a lot of the time, they fall and they break bones because they're not being watched or assisted properly. And in 3 consecutive periods of time, complaints were made about such incidents by relatives of elderly people. And each time they got an apology, they got a copy of an action plan as to what was being done to make sure this didn't happen again. And then it would happen again, and the same action plan would be trotted out. So a process was being gone through, but no thought applied to it. And but there were people who often said no one knew what was going on in Stafford. They did. A whistleblower in 2005, a whistleblowing nurse, expressed real concern about the care being offered in one particular ward, and very properly the management got in an external senior nurse to look at what was going on there. And she found that a great deal was going wrong, and that there wasn't a commitment at the highest levels in the trust to solve the problem. She handed that report to the interim chief executive of the Trust, who gave a copy of it to the chair of the Trust. And you might have thought, therefore, a lot of action was then taken. It wasn't. The report was buried. It was not reported to the board. And as far as I could work out, over 2 inquiries, no action was taken on that report at all. And it sort of came to light in my inquiries almost by accident. And why didn't it go to the board? Because the chair of the board considered that its responsibility was to look at strategic matters, not operational, and this was classified as operational and therefore not something for the non-executive board to think about. You might take a different view. Then later, a lady died in 2007, coincidentally the same month as the worst of the mortality figures were reported. She was an insulin-dependent diabetic, and she came in with a broken leg. The emergency department recorded in the records that she was an insulin-dependent diabetic. She was in hospital 11 days before she died, and she died not because of any complication of her broken leg, but because she hadn't been given insulin. And for good measure, she was meant to get dietetic advice and assistance, and none of that had happened either. So after her death, the trust solicitor, lawyer, in-house lawyer, did a report. And these were his findings. These were the things that he reported to his chairman had gone wrong. And you might think, looking at that one report alone, you'd think this is a hospital in real trouble where their own in-house lawyer is telling them these are the things that are going wrong. Did that report go to the board? No. Was it reported outside that organisation in any real way? There was a formal serious incident report filed? No. That report, the computer entry of an incident was never looked at by the outside body that was meant to look at them until after my inquiry had started. Now, then there was the doctor who turned up in the emergency department, a trainee, a senior trainee from another hospital, and he was horrified by what he saw. And he told me a very long story about it, but those are a summary of the things that he thought were wrong. And he tried to raise those issues as a senior trainee with his own consultant in the hospital, who told him there was nothing he could do about it. He raised it with his training organisation, who began to do something about it, but not very much. He came to a conference of his specialty, and he went to a breakout group, and he raised the issue there. He received lots of expressions of concern, but no one decided they would do anything. No one offered him real and concrete help. The Royal College of Surgeons, no less, was asked by the Trust to come and review a problem they had in the surgical department, which was largely around a feud and a personality difference between two surgeons. I'm sure you don't have that here. And but they found something rather more serious than that. This was distinguished surgeons who came to look at it. One of them became president of the Royal College. And their report to the Trust was that the surgical department was dysfunctional, lacking in effective leadership. There was no working relationship between various people, and they couldn't agree on protocols. So the result was that when these two surgeons were on duty, the operating theatre staff didn't know what equipment to put out for the same operation because they couldn't agree on something as basic as that, and no one had done anything to make them do so. So they made various recommendations. What happened to that report? Well, it was considered in summary form by the board, but no effective action was taken. And when after the balloon had gone up, the Royal College was asked to come back again, the cost of that inaction was shown. The cost included the fact that they now said that the department was dangerous. And they thought that because they undertook a review of cases. And they found so many grossly negligent cases, they really didn't know where to start. And one of the worst cases involved one of the surgeons that I've just mentioned, who failed to take advice from a multidisciplinary group about a very difficult surgical case. He had taken the advice, and the advice was the patient isn't fit for surgery. he went on and operated regardless, and the patient died on the operating table. That was the sort of thing that's happening at this hospital. So what was the reaction of the Trust to all this and to the furore that followed? Well, the chair of the Trust told me this. When asked, is the large number of people complaining about the same thing might be a reflection that the same sort of poor care was happening to a number of different people, do you accept that? Answer, I think it's much, much more likely that the reason a huge number of people didn't find anything uniquely dreadful is there was nothing uniquely dreadful to find out. And that's still your belief. This was after the first report and in the middle of the second inquiry. Answer, yes. It is so easy for well-intentioned people to blind themselves to what actually is in front of their eyes. So what went wrong? Why did things go wrong? This slide, I'm afraid, is a part of my COD sociology. I'm not a sociologist. I'm very bad at diagrams. But what I'm trying to get through to people about is that there's a vicious cycle that develops in an organisation, and it becomes very difficult to break out of it because a number of factors interact with each other. In our system at the time all this was happening, there were, as there are in any system of healthcare, a large number of pressures bearing down on the poor people who have to deliver the care. And in our case, they included targets, real serious consequences developed if you didn't meet the emergency waiting time target of 4 hours. That's 4 hours to complete the treatment and discharge from the department under any circumstances, and the required pass rate was 98.5%, which, if you think about it, is really quite difficult to achieve. And this trust, it was achieved sometimes by fabricating the figures. Reorganisation. I'll come on to that a bit in a moment. There's constant reorganisation of bits of the National Health Service, which would mean that people were spending far more time on the minutiae of how to reorganise things and where their next job was going to be than not actually the job they were meant to be doing. There's, of course, finance. I heard the Minister mention it here. It's true of any health system in the world that there has to be downward pressure on how much is spent, because otherwise you never stop. But that can lead to the wrong things being done. It can lead to staff being cut from places where staff are actually needed. So these are the sorts of pressures. And they, I think, lead to reactions. There's the fear, above all, a fear that you might lose your job. Chief executives in our country of hospital trusts have an average tenure in office of less than 2 years. And when you think that 1 or 2 of the rather successful ones have been there for 10 to 15 years, there must be some who've hardly got down to their desk before they're out of the door again. And therefore, they're not going to be listened to, or if they are, it's because they're undertaking brutal tactics, which really are counterproductive. There is the disengagement. I'm not going to deal with all these points. The pressure leads to professional staff shrugging their shoulders and thinking, well, I can't do anything about this. I've just got to get on with my job. It leads to a closing in, so that there's no openness, there's no frank discussion about the things that are going wrong. This, I think, then leads to a group of behaviours which appear to be uncaring. There is bullying of people to do things they wouldn't otherwise be happy in doing. There's the pushing relatives, for instance, away. So you make it difficult for people to come and visit you. And there's just keeping your head down and getting on with things. And then there's the habituation. There's the tolerance of the intolerable, which develops because you see it so often. That's just the way it is. There's a denial that really it's as bad as that, and I've given you an example of that. There is the reliance on external reassurance. In our country, we have a number of bodies that monitor the standards being provided. And if they give you a pass, that's thought to be reassurance that everything's all right. But of course, no regulator, no overseer from outside an institution can ever know as much about what's going on as those within, or at least that should be the case. And finally, in a complicated system, it's always easy to find someone else who is responsible for doing what you should be doing. It's very easy for that at all levels to permeate, and I'm afraid that's what happened here. There is a wider issue, which is the tolerance of the public, wider public, for bad care, which I don't think we pay enough attention to. Since my 2 inquiries and everything that's been said about the Stafford Hospital and the things that have gone wrong there, there's been absolute outrage in the community of Stafford for the fact that this has, they think, disgraced the town, because it hasn't done that. Their hospital has real difficulties now because it can't attract staff and all the rest of it, and steps are being taken in effect to distribute its services to other places. But this results in, for instance, Julie Bailey, here pictured again, receiving on Facebook the wish that I put on the screen, that basically from an ambulance driver this was, that she gets a terminal illness, so that when she's put in an ambulance, there isn't a hospital for her to go to. That ambulance driver is no longer in the service, but it tells you something of what's going on. There are demonstrations through the streets of town protesting about this. This poor lady's mother, who was the patient in hospital's grave, gets desecrated, and she then gets sent emails about it. So the strength of feeling is extraordinarily high, even in the face of all the evidence. The effect on staff is shown, I think, by this. A nurse who was a conscientious nurse, wanting to do the best thing, but she would always go home feeling she hadn't been able to do her job properly. And that saps the morale. It leads to increased sickness rates and absenteeism, which is quite a good sign of whether things are going well or badly in our hospital. The habituation, the doctor in the emergency department I mentioned to you, told me that his theory was that if you are in that environment for long enough, what happens is you become immune to the sound of pain. You either become immune to the sound of pain or you walk away. You cannot feel people's pain. You cannot continue to want to do the best you possibly can when the system says no to you. You just can't do the best. You just do the best you can. Less praiseworthy was this. A senior consultant, soon to retire, one might think was a good thing, told me this as an explanation for why he hadn't raised more of a fuss. There was the excuse that most of his patients weren't directly affected. There was the feeling that he was going to retire soon anyway, and I shouldn't rock the boat at my stage in life because, for example, I needed discretionary points or to be put forward for clinical excellence awards. Now, I'm all in favour of candour, and that is candour, and I suspect that professional self-interest lies at the heart of much more than we're ever prepared to admit to. But so does fear. The leader of the British Medical Association said this recently at a conference, that many doctors express fear about the consequences, and this inhibits us from doing what we know to be right. And I find it rather sad that a profession that has dedicated itself to the care of the sick feels that fear, and it is fear of one's own position, gets in the way of doing the right thing. And I think we need to think carefully about that. Then there's the isolation through lack of candour. I won't tell you the very long story behind this slide, but essentially a young man died because of inadequate care in the emergency department, and the senior consultant was asked to write a report about it for the coroner. And in the report, he said that this death was unavoidable because the patient hadn't been examined properly. The in-house lawyer of the trust asked him to remove those passages from his report for two reasons. One, because it would cause undue distress to the deceased family, and the other was the adverse publicity for the trust. Sadly, eventually, under pressure, the consultant agreed to do that, but the report in neither form was ever sent to the coroner. But more importantly, the family didn't get told until my inquiry that there was anyone in the trust who actually thought that this was the case. Leadership change. We're not going to ask you who all these people are on the slide. Even I barely know who they all are. But one of the problems, I think, in a lot of health systems, certainly ours, is at every single level, leadership keeps on changing. So in the time I was looking at, we've had all those ministers of health. The current one is the guy in the helmet at the end, that's because he rides a bike, not because he's Secretary of State for Health. The permanent secretaries, the senior officials in the civil service have changed several times, as have the chief executives at virtually all levels of the National Health Service. The commissioners, the way in which things are commissioned has changed. We've been through 2 different regulators for quality and several different leaderships within those. So if you're working at the front line, trying to do your best, looking after for patients, you look upwards and you look away very quickly because you have really no idea and therefore a decreasing interest in what is going on there. One of the big things in this trust was the board were people who were conscientious, who wanted to do the right thing by their patients, but never got the right level of information. And why was that? Well, the first was the one I've already mentioned, that they insisted on defining things which were problems as operational and not to concern them, and other things, the good news, tended to be strategic. They didn't receive information in any usable form about complaints, not for a long time anyway. The incident investigations weren't reported to them. They discounted the mortality statistics on the advice that they were given. They had one doctor, one nurse on the board, executive board that was. The consultants committee was weak. They relied on all sorts of external ratings. They ignored what the staff raised by way of concern through the guys in that caravan. They just didn't really listen to what they had to say. They would say that, wouldn't they, as tends to be the sort of reaction to staff representation. And then there was the financial pressures. They resorted to staff reductions, salami slicing nursing staff year by year. So each number looked pretty small. But when you added it up over a period of time, actually, what had started off as a low level of staffing became completely inadequate. And staffing reductions were made without any documented, that I could find, any documented risk assessment. They were just assurances that we'd looked into that and it would be fine. And then there was the corporate optimism, the can-do attitude. We're going to be fine, based on, frankly, remarkably little evidence. I've given you, I think, some of the examples of the lack of transparency and candour, but the regulators were told that they didn't have a problem with mortality. The quality is our business, and when they got foundation trust status, which is a form of autonomy in our system, they trumpeted the fact that they were in the Premier League now. That was 6 weeks before the Healthcare Commission started its investigation. And there was a lack of urgency. I'm not going to deal with all these things, but there was a lack of urgency about dealing with problems they did know about. So that when a director of nursing did say that the skill mix needed review because it didn't look right to her, it took 18 months to actually produce a report, and no one pushed for that. And when the report came in, it wasn't actually the change that was needed was not implemented straight away. Now, what chance of coordinated action when, in relation to all the information that was there, when this, in the same document I said to you before, is what's meant to happen? And it actually, all those columns actually underlying that are a large number of organisations, all of which have got to know the same information, and all of which have got to take coordinated action. So it's not hugely surprising if you have that sort of complexity, that it takes a long time for bad things to be stopped. So how do you change all this? Well, I'm not going to go through 290 recommendations with you today, but the themes behind what I thought was important was firstly that you need to ensure not only that there are common values throughout your healthcare system, but everyone knows and understands and lives by them. And that sounds easy, but it's not as easy to implement as in reality. And within your system, you need some fundamental values and fundamental standards that are easy to understand by the people who work at the front line, by patients and by staff, so that when things aren't being produced to that standard, everyone knows that that is the case and is empowered to do something about it. Openness, transparency and candour, I'll come to in a little detail. Nursing, we take for granted, don't we, that our nurses are compassionate, caring, committed, and my God, they are. But I'm afraid all that can be crushed out of them by a system that doesn't train them properly, doesn't support them properly, and doesn't monitor them in the work that they do and lead them properly. And so we need to watch that. We need to make sure we have systems in place that make sure that we do maintain compassionate and caring and committed nursing staff. We need to put the patient at the centre of things, which everyone says it, but it's very easy with all the pressures for everyone to do the systems business rather than the patient. None of this can happen unless we have better information. The HSMR and that sort of thing, access targets, are not enough. And we need to work very hard, I think, to get better information about how things are going. And culture change isn't dependent on the government in our country, really, although it thinks it is. It isn't dependent on a national organisation. Culture change can be dealt with and should be dealt with on a ward basis, a divisional basis, and within a hospital. And if we don't do that, then all the pronouncements from above are going to make no difference at all. We are beginning to formulate in our country some fundamental standards through the Care Quality Commission. And I recommended a number, and the list, of course, has grown. And the whole point about these is that they symbolise things which just will not be tolerated, that there will be serious consequences if they don't happen, and including, if necessary, criminal prosecution. Openness, transparency and candour, those are my definitions of it. One, openness involves welcoming complaints, welcoming the expression of concerns. Transparency is about telling people what's gone wrong as well as what's gone right. And candour is about being honest with patients when they've been harmed avoidably harmed by treatment. Some examples of this, of openness, we have a long and dishonourable history of when people are dismissed over disagreements and having a clause called a non-disparagement clause put in their contract. So they lose their compensation if they break ranks and actually say what's been going on there. We're getting rid of those. We need more independent investigation in our country of things that have gone wrong rather than in-house investigations. We need real feedback to people who have complained, whether they be staff who've complained, patients who've complained, or staff. And we need information about what's gone wrong shared much more widely than it has been. A lot's been going on in our country now about nursing. We now are requiring a hands-on experience as a pre-entry requirement to qualified nursing. And there are a number of other things happening in that field. Leadership. We have lots of leadership, too many leaders perhaps, but rather little by way of accountability of those who are leaders, particularly those who are not professionally qualified, medically professionally qualified. And we are seeking to develop better means of holding to public account those who have failed really seriously in the leadership of hospital organisations. Information. One of the really encouraging things that I've seen is the willingness of the specialists, professionals, cardiologists, vascular surgeons in particular at the moment, to work on means of measuring the effectiveness of their work and then publishing that. You can now find online in our country, and I know you can in various other places in the world as well, information down to an individual level of the outcome measures for individual surgeons. So, is it all doom and gloom? And the answer is no. Firstly, the government in our country has committed itself to all the objectives identified in my inquiry and those that have followed. And most of the recommendations, remarkably, have actually been accepted. Candour is being displayed remarkably, if I may say so, don't know if the minister's still here, but at high level, the Secretary of State gets criticised because he accepts that there is mediocre care being delivered in the NHS and that must improve. The Care Quality Commission, the regulator, has apologised in public for its failure to handle properly a scandal at another trust. And an example of a hospital trust which actually puts on a board in the ward what level of staff are needed there and how many they've actually got. So that the public can see, walking into the ward, is this ward properly staffed or is it not? We do have a regulator which is now undertaking expert-led inspections, and by experts I mean not just doctors and nurses doing the inspections, but also what they call experts by experience, patients who will go around the hospital with the team of inspectors. And it does mean it's a bit resource-intensive business. We have inspection teams of 30 or 40 people will now spend a week or so in a hospital, in effect taking it apart, and to great effect, it seems, on the short amount of experience we've had so far. And the profession, as I've already mentioned, have become really engaged in how to improve things. So an example of that is the Royal College of Physicians has published a seminal report, and I commend it to you, from what it calls its Future Hospital Commission, which is how to make hospitals fit for purpose in the modern age. And frontline experience, I think one of my proudest achievements, we've heard about the minister here going around hospitals. In our country, the Department of Health is requiring all of the civil servants and ministers to go out and actually work for 4 weeks a year in hospitals. And they're actually doing it. And they're coming back with a wealth of information they would never have had otherwise. So there's a lot of activity going on. The lady in the bottom left-hand corner of that slide is a Department of Health civil servant, and I put that up there for this reason. She writes a blog, and recently in her blog, she described in pretty critical terms an experience of care she received in a hospital. I can't imagine that happening before a real spirit of candour was adopted in our country. But finally, just a thought. My stepdaughter recently went to Nepal and worked in a leprosy hospital there. And at the front door of this place, which is built because of the social stigma attached to leprosy in Nepal, was this notice, which it seems to me, it's a motivational phrase, slightly bowdlerised, that you'll see in other places, but I think it's particularly pertinent to end this talk with it. What it said was, people affected by leprosy are the most important visitors on our premises. They're not dependent on us, we're dependent on them. Service to them is purpose of our work. They are not outsiders to our service, they're part of it. We're not doing them a favour by serving them. They're giving us an opportunity to do so. Thank you very much.